Thank you all very much. Thank you, Dr. Haqqani, for inviting me to be part of this symposium. It's really an honor to be here and to be part of the community. My talk is going to be about basically the medical management of the vascular patient. I mean, clearly we can't do that all in 25 minutes, but it's going to be relatively a generalized overview of the important aspects of taking care of vascular patients. So we're going to discuss the epidemiology, the diagnostic data, the medical management of people with PAD, and then look at reasons for revascularization and the guidelines. So clearly, PAD and vascular disease is very prevalent in the United States and internationally as well. Around 10 million people in the US have vascular disease, and it becomes more of a problem as you get older. So the prevalence increases with age. And every person with vascular disease has a composite problem of either stroke, heart attacks, or like peripheral arterial disease. So as you can see, the prevalence increases with age, and it's more common in the male gender. And in the United States, the people are getting older. So we expect that there's going to be a higher incidence and prevalence of patients with vascular disease. We talk mostly about composite outcomes. That's usually myocardial infarction, stroke, and peripheral arterial disease. And as you can see up on the slide, clearly there's the highest amount of mortality with myocardial infarction, but there's the highest prevalence with people with PAD. So these people live for a long time, and we have to deal with their disease process for a significant amount of time. And as vascular interventionalists, that's where we get mostly involved. So as you can see, the more severe the PAD, the higher a chance of mortality. So it's a concurrent problem between PAD and coronary disease. As a matter of fact, I tell my students, my trainees, that there's no such thing as peripheral arterial disease. I think it's a misnomer. It's an extension of coronary artery disease. So the vascular system is all intertwined and all involved. And so if you have a high amount of peripheral problems, you also have a high amount of coronary problems. And that's what tends to take patients at the end of life. So with regards to epidemiology, atherosclerotic disease is most common in the proximal vessels. People that have end-stage renal disease or diabetics tend to have more distal disease, and that tends to be much more challenging with regards to people with PAD. The risk factors are myriad. They'll tell you that there are modifiable and non-modifiable risk factors. Clearly, the non-modifiable ones are age, race, sex. The modifiable ones involve, lifestyle things like alcohol, smoking, hypertension, hypercholesterolemia. As you can see there, most of our patients are either smokers, have diabetes, hypertension, and hyperlipidemia, and we want to work very hard on managing those risk factors, and we'll discuss that shortly. You can see here, despite all the ones that are there, the ones that matter the most, that we have a good opportunity to be involved in is tobacco cessation and strict management of blood pressure or antihypertensive medication. But this is what I was referring to earlier. It's really all intertwined. So coronary artery disease, CVD, cerebrovascular disease, and PAD, peripheral arterial disease, they're really not mutually exclusive. And a large portion of patients tend to have an element of all. And that tends to be very challenging with regards to surgical management and particular medical management as well. So as we touched on previously, patients with peripheral arterial disease, stroke, or myocardial infarction have a higher mortality because there's an extension towards the coronary vasculature. As you can see there, you have an increased risk of stroke, an increased rate of MI if you have PAD. If you have patients with coronary disease, you have an increased risk of stroke and peripheral arterial disease, and vice versa. So they're all intertwined. Like I said, they're not mutually exclusive, and it's important on behalf of the specialist to be able to check for all of them. As I'm sure Dr. Haqqani and others here will tell you, patients come in with peripheral arterial disease, we check for carotid disease, we check for coronary disease. We want to make sure that the patient is managed comprehensively from a vascular perspective. So again, I'm just pushing this point home. People with peripheral disease have higher mortality. And that's why it's very important to challenge that and tend to work towards minimizing that. With regards to peripheral arterial disease, again, 50% of the patients are really asymptomatic. We find out about them by having a high index of suspicion, things that you all help us with as a specialists. You say, hey, this person's a smoker, has got diabetes, got high blood pressure that's uncontrolled, has hyperlipidemia. Well, let's just check. They may have quiescent peripheral arterial disease or asymptomatic status, and that's where ABIs and testing gets involved. Clearly, 15% only of them have classical symptoms, and those are the easy ones. You already know what's going on, but then the other ones are the ones that you have to figure out. And through use of your specialists, through use of diagnostic testing, with your ultrasound staff, and so forth, that's how you can uncover patients that have asymptomatic disease. And just because they're not suffering from it does not mean it's not there. And it's the ability to capture those patients where we can make the greatest impact on the management of patients with cardiovascular disease. So with regards to claudication, I'm going to focus a little bit on PAD. It depends on the site of the problem. If you have iliac disease, patients tend to complain of buttock pain or erectile dysfunction. If it's more distal, like the external iliac or common femoral, they tend to complain of thigh and calf pain. And then if it's the femoral popliteal region, they tend to complain of calf pain. So that helps us identify the location of the problem even before any diagnostic imaging, just on clinical discussion and examination with the patient. This is a lot of patients that I see, or we mostly see in our practice, and this is what you want to avoid: critical limb ischemia, which encompasses rest pain and obviously gangrene or tissue loss. Those patients have a high risk of limb loss, actually around 35% per year. So something has to be done for patients with critical limb ischemia. They come in with constant pain or tissue loss, they have to be referred to a vascular specialist or surgeon in order to be able to manage that. Without intervention, they will lose the limb. That's different than acute limb ischemia, where patients come in with pain or pallor and so forth. That is a surgical emergency. And as you can see, the right foot on the left side of the screen is pale as compared to the left side, and that patient presents with acute limb ischemia. You want to be able to utilize the diagnostic methods available to you. A variety are available to you, including ABIs, which is diagnostic physiologic tests, lower extremity arterial duplex, which is more anatomic information, CT and MR angiography, and then the gold standard is a catheter-based angiogram, which I am a fan of because it allows you to have diagnostic information, but at the same time, you can have a therapeutic intervention. The problem with that is that there is risks associated with any intervention, so we want to make sure that we're doing catheter-based angiograms on people we feel are going to require some sort of intervention. Okay, it's the tiebreaker in all of vascular surgery. It's the gold standard. The ABIs, very briefly, is something that can be done in your office, or if you have an accredited vascular lab, they can help you identify that. And that just goes to tell you what the blood pressure is in the extremity, in the lower extremity as compared to the upper extremity. And the ratio between the two should be 1, because the blood pressure in your foot should be the same as the blood pressure in your arm. There are some exceptions to that, and you can have non-compressible vessels, particularly in diabetics. We don't need to get into all that, but the point is they should be similar. If your blood flow in the right leg is different than the blood flow in the left arm, then there's a blockage along the way. And that helps you decide what next needs to be done. And that's based on the clinical symptoms of the patient. Exercise ABIs, I'm a very big fan of. And any patient that can undergo that, I recommend that strongly. Patients at rest may have normal blood flow and say, oh, this patient's doing fine, his ABI is normal. But as soon as they start walking or exercising, then your tissues require more energy. You get that in the form of blood. The blood needs to get there. And so if it can't get there quick enough, they start cramping, they start complaining of pain. And so you can unmask a normal resting ABI by putting the patient through some sort of exercise. So any person that can actually, in fact, exercise, I would recommend that. And that's relatively simple. It's at 1.2 miles per hour treadmill, and they walk, and then if they get some pain, they tell the tech, and then the tech calls you. Okay. Well, why do I push ABIs? It's a physiologic test, but then because ABIs do, in fact, predict survival. If you have a worse ABI, that means you have worse blockages, narrowings, if you will, and blood's not getting to your extremities. And by extension, if it's not getting to your extremities, that means you probably have blockages in the coronary system. So if your ABI is very, very poor, that tends to predict survival. So we want to manage PAD. Patients complaining of pain in the leg, we got to take care of that. Okay, that's great. I think it's important to manage the patient's symptoms. That's a critical component of healthcare. But the more important thing, and I challenge everybody here, is that it is an extension of coronary disease. So you really want to manage their PAD in an effort to decrease their overall cardiovascular risk. Okay? The most important thing about managing vascular disease is preventing future cardiovascular events. I understand you want to help them with the leg, with the arm, whatever it may be, that's great. But the point is you want to help decrease future cardiovascular events. So the onus is on the provider to be able to check for that, to make sure that you have a comprehensive examination. And that can be done, again, with the medical management, including smoking cessation, lifestyle factors, increasing exercise tolerance, lipid-lowering agents, antihypertensives, and the like, antiplatelets. A variety of studies have been done. My medical counterparts can probably discuss this ad nauseum, but a variety of trials were performed, the Capri, the Pegasus, and the Euclid, again, showing the use of antiplatelet agents in the management of patients with peripheral arterial disease. And as you can see in the Capri, patients had less CVI, MI, and death. That's what we call the composite cardiovascular outcome in patients undergoing Plavix with almost a 9% relative risk reduction. You have a 4.1% risk reduction in major adverse cardiovascular events. That's what MACE stands for, in patients undergoing with Brilinta. But again, if you put them on antiplatelet agents, you have to always balance the concern for increased bleeding. The COMPASS trial came out in New England Journal of Medicine just lately. So you can see here, patients that had rivaroxaban, which is a direct oral anticoagulant, did better than patients on aspirin alone in a variety of composite outcomes, including stroke, cardiovascular death, and death from any cause. These are all statistically significant, as you can see with the confidence intervals noted to the screen. For me, interestingly as well, patients with rivaroxaban and aspirin had a statistically significant decrease in major amputation, which is the goal of limb salvage for vascular surgeons. And these patients were on a dose of 2.5 milligrams orally twice a day. So all these in all these outcomes, except for MI, cardiovascular death, were statistically significant with this dose. Lipid lowering, I'm just going to touch briefly because Dr. Dan Lee is the professional when it comes to lipids. I'm going to let him do his talk on that. But the point is, it's very important that patients are maintained on lipid-lowering medication. I'm pushing this very strongly, and I have this discussion with my patients a lot. Patients that are on HMG-CoA reductase inhibitors or statins help to decrease lipids. Well, they tell you, well, doctor, my cholesterol is fine, my lipids are fine. I understand that, but the lipids and statins work through what we call a pleiotropic effect. So it has some anti-inflammatory properties that we don't know all really the true mechanism of it, but it's been shown to decrease mortality, aneurysm growth, and aneurysm rupture in a variety of large base trials, particularly vascular surgery. So all vascular patients, in my estimation, should be on statin therapy, even if their cholesterol and their triglycerides are abnormal. ACE inhibitors, again, have been shown that ramipril has been shown to decrease cardiovascular death and the composite outcome of myocardial infarction and stroke. So ACE inhibitors are very important when it comes to the management of PAD. Again, the spectrum of management moves from exercise, medication management, surgical intervention, and there are investigational opportunities as well. A supervised exercise program, which is now covered by Medicare, is important. You can see here in this study on a variety of meta-analyses that the forest plot shows that it favors exercise. People do better if they have a supervised exercise program. That involves 30 minutes 3 times per week. So I think it's important that you encourage your patients to be involved in that. Again, a home exercise program has also been shown to be beneficial with regards to the study over there, statistically significant to the left on those forest plot. Medical therapy. And this is something we see with our patients quite dramatically. Cilostazol or Pletal, which is a trade name, is the only approved FDA drug for the management of patients with intermittent claudication. The dose is 100 milligrams orally twice a day, but it does have some side effects. I'll discuss that here shortly, but cilostazol is a phosphodiesterase 3 inhibitor. It increases GMP, which helps to cause vasodilation. Okay, just like it causes vasodilation in the lower extremities, it can cause that in the head and cause headaches, which tends to be the primary reason why people discontinue it. And also, the other major side effect is diarrhea. And I have this, I always have this weird picture in my mind because I always think of the claudicant who can't really walk and is trying to get to the bathroom quick enough because, they have diarrhea. And I always feel bad. So I always let them know that before I put them on it. Like I said, it's 100 milligrams twice a day. If it tends to bother the patient, I tell them to take half a dose. So 50 in the morning and 100 at night because they're sleeping and they won't notice it. And if it's still bothering them, then I ask them to take 50 twice a day. And if it's still bothering them, then I tell them to stop. The medication takes a while to kick in. So trying it for a couple of days or a week is not sufficient. They should try it. The latest data actually says they should try it for 3 months. But I at least put them on a course for around 6 weeks to see how they do. Again, I touched on ACE inhibitors. Ramipril has been very helpful. You can see there just to the right of the forest plot. Okay, and the possible mechanism of action of ramipril, again, is inhibiting angiotensin II, which is a vasoconstrictor, ultimately causing vasodilatation. And again, this had a positive result with regards to composite cardiovascular death. So these patients should be managed and loaded on these. So let's talk about the guidelines real quick, okay? Review of the guidelines demonstrate that antiplatelet agents with aspirin is recommended to reduce MI, stroke, and vascular death in patients with symptomatic PAD. This is different than primary prevention. I'll let some of my colleagues discuss that. It's not recommended by the AHA that patients be placed on antiplatelet agents for primary prevention, but these are patients for secondary prevention. They've had some sort of cardiovascular concern. Statin agents is indicated for all patients with PAD. This is a 1A recommendation. I'm very much in support of that, particularly vascular surgical patients with aneurysmal disease. And again, antihypertensive agents, 1A. You got to manage them medically before you can deal with them surgically, or else your outcomes will be suboptimal. Furthermore, exercise program. Now it's, I said, covered by CMS and Medicare. They should all be involved in that. And then psilocybin 1A is effective to improve symptoms and increase walking distance in patients with claudication. So they should all try these, and they should fail these before considering investigational opportunities. Real quickly, the indications for revascularization are lifestyle limiting or disabling claudication. So you have a mailman that can't do his or her job because they can't walk around. Not just that they're not having a good time on the golf course, unless they're retired and that's all they want to do. The other indication, like I said, is critical limb ischemia, which encompasses rest pain and tissue loss. There's a regular patient that we see all the time. It's before dinner, so I left it up there for you all. This person has to have they have to have something done, or they will lose the limb, 35% per year, if they don't succumb to coronary disease before that. Okay? All our patients require preoperative evaluation because they have some element of coronary artery disease. Anybody with high-risk features? I think that EKG is normal, but I don't know. Joking. And then patients that have urgent or emergent indications, they go to surgery because the benefit outweighs the risk. You just have to accept the risk of surgery in order for them to undergo that. For people that can be done electively, they go through a barrage of questions and tests. They have anginal symptoms, arrhythmias, valvular disease, and so forth. Is a patient at higher risk than a normal patient? Well, history of CHF, cerebrovascular disease, AFib, obesity. There are a variety of algorithms. This is the one by the American Heart Association. I encourage that you consult your cardiologist or medical specialist in regards to cardiac risk stratification for patients undergoing vascular surgery. So I put, when in doubt, consult the cardiologist. They're professionals at that. If you're not sure, ask him or her. They'll be able to assist you in that. So in conclusion, vascular patients are sick. They're sick. The management of the vascular patients encompasses a wide spectrum. Risk factor modification is imperative. Lifestyle factors need to be dealt with. Medication first, and if all that, you've reached a plateau with that, or it's not working, then at that point intervention is indicated. And remember, the focus of management is to minimize future cardiovascular events. Okay, that is the goal of the management in these patients. Thank you very much for your time and attention.